Go to the drawer or cabinet where you keep drugstore medicines. Bring the cold medicine, pain reliever, nasal spray, and anything that fizzes in water. Place them beside your blood pressure bottles. Do not stop or change a prescription because of this video. Nothing here means stop a prescription. It means bring the box to your pharmacist before you add something to it. Nobody told you this because it was a secret. Often, nobody asked what else you were taking. Let us fix that, starting with number 7. Number 7 is an oral decongestant containing pseudoephedrine or phenylephrine. You may buy it for a blocked nose, sinus pressure, or a miserable cold. The front of the box may emphasize fast relief. The line that matters for this conversation is the active ingredient line. That distinction matters because the same active ingredient can sit behind very different promises on the front of a package. One box may say sinus. Another may say daytime. A third may emphasize pressure or congestion. You do not have to learn every package name. You are looking for the ingredient that tells you what the medicine actually does. Decongestants work by narrowing blood vessels, and that can raise blood pressure. That does not predict what will happen to you, and it does not make every product equally risky. It does mean the drugstore shelf and your prescription list should not be treated as two separate worlds. Guidelines suggest using decongestants for the shortest time possible or asking about saline spray or an antihistamine instead. Which option fits you is a question for your pharmacist. Here is the exact question to use. Does this contain a decongestant that can raise blood pressure, and would saline spray or an antihistamine fit my medication list better? That is not being difficult. That is giving the pharmacist the one piece of information the shelf cannot see. Number 6 is a common over-the-counter pain reliever such as Ibuprofen or naproxen. These medicines are called nonsteroidal anti-inflammatory drugs, or NSAIDs. Common over-the-counter NSAIDs can make the body hold on to more sodium and fluid, and that can push blood pressure up. They already carry a label warning about heart attack and stroke risk. The important word is can. This is not a promise that one tablet will raise every person's pressure. It is a reason to ask before turning an occasional purchase into a routine. And do not guess at the substitute. Guidelines point to topical anti-inflammatory gels or acetaminophen as alternatives to pills, but the right choice still depends on the person and the rest of the medication list. Ask, with my blood pressure prescriptions, is this oral pain reliever appropriate for me? Or should I ask about a topical gel or acetaminophen? Notice what that question does. It does not ask you to endure pain. It asks the system to consider the whole list instead of one symptom at a time. Imagine the ordinary sequence. A knee begins to ache on Saturday. The doctor's office has your prescription list, but the drugstore decision happens somewhere else. The person reaches for the familiar pain relief box because it has worked before. Nothing dramatic or reckless has happened. The missing step is simply that nobody has connected that familiar box to today's prescription list. Number 5 is the core of this video. Medicine that dissolves, disperses, or fizzes in water. Imagine a typical situation. This is not a patient story. A person has spent years leaving the salt shaker alone. They taste the soup before seasoning it. They read food labels. Every morning, though, they drop a tablet into a glass, watch it fizz, and drink it without ever thinking of that glass as part of their sodium intake. In our first video, we talked about salt and salt substitutes because less salty and right for my prescriptions are not always the same question. This is the other side of that lesson. Sodium can arrive from a form of medicine, not only from food. A large British observational study compared sodium-containing dissolvable, effervescent, or dispersible versions of medicines with ordinary versions of the very same drugs. The data covered more than 1 million patients. People taking the sodium-containing forms were more likely to be diagnosed with high blood pressure. For that diagnosis, the study reported an odds ratio of 7.18. The sodium-containing group also had a higher rate of stroke and of death from any cause. Now the boundary that keeps this honest. This was an observational finding. It shows a strong association, not proof that the sodium alone caused those outcomes. The data came from Britain, and the study cannot tell you what will happen to one individual. It also does not support the line that these forms raise heart attack risk. Non-fatal heart attack, considered separately, was not increased in that study. The elevated findings were the combined cardiovascular outcome, stroke, high blood pressure diagnosis, and death from any cause. Precision matters, especially when a headline is frightening. The comparison is what makes this study so useful for the medicine cabinet exercise. It was not simply people who take medicine compared with people who do not. It compared sodium-containing forms with ordinary forms of the same drugs. The form of the medicine was the detail being examined. That is why two packages with the same familiar medicine name may still deserve a closer look. For some products in the study, the maximum daily dose on the box would put a person over the recommended daily sodium limit before a single bite of food. The answer is not, never take anything that fizzes. The authors called for caution when these forms are used. Your action is simpler. Turn the package around and ask, does this dissolvable or effervescent form contain sodium? And is a regular tablet or another form appropriate for me? Do not switch a prescribed formulation on your own. Bring the tube, packet, or a clear photograph of its label to the pharmacist. This is exactly why people feel blindsided. You can do everything you were told at the dinner table and still never be asked what goes into the glass beside it. And that is the callback I want you to remember from video number 1. We looked at the salt shaker and the salt substitute. Now widen the frame. Look at the glass, the tube, and the word effervescent. The lesson is not that you failed to avoid salt. The lesson is that the sodium conversation was never finished if it stopped at food. Number 4 is a decongestant nasal spray containing oxymetazoline. I separated sprays from pills because they sit in a different part of the aisle and are easy to mentally file as just a spray. This is not a danger ranking. It is a search strategy for your medicine cabinet. Oxymetazoline is a decongestant. Decongestants work by narrowing blood vessels, and that can raise blood pressure. The safe action is not to make your own blanket rule. Guidelines suggest using decongestants for the shortest time possible or asking about saline spray or an antihistamine instead. Use this question. I take medicine for blood pressure. Is this oxymetazoline spray appropriate for me? And what non-decongestant option could fit instead? A capable person does not need to memorize a pharmacology textbook. You need the active ingredient and one precise question. Number 3 is the all-in-one cold or flu product. One package can combine a decongestant with an NSAID pain reliever. That puts 2 already confirmed mechanisms behind one friendly front label. The decongestant narrows blood vessels and can raise blood pressure. The NSAID can make the body retain more sodium and fluid, which can also push pressure up. This is where the system often fails the person doing everything right. The clinician sees the prescription list. The drugstore shelf sees a cough, a stuffy nose, and an aching head. Unless somebody asks what is happening in both places, the complete picture never appears. There is another reason these boxes deserve a slower turn in your hand. A person may remember choosing cold medicine, not choosing a decongestant and a pain reliever together. That is understandable. The front label organizes the product around symptoms. The back label organizes it around ingredients. For a medication check, the back is the part that can be compared with your prescriptions. Do not rely on the product name. Read the active ingredients panel, because that is where pseudoephedrine, phenylephrine, ibuprofen, or naproxen would be named. Then ask one question. Does this multi-symptom product contain a decongestant or an NSAID that could affect my blood pressure or medication plan? If the pharmacist points you towards saline spray, an antihistamine, a topical anti-inflammatory gel, or acetaminophen, ask which one fits you. Available without a prescription is a purchasing category. It is not a personalized medication review. A viewer wrote under our second video, anybody with a decent doctor will require a visit every few months. Check how you're doing. and do labs that show how the Rx is affecting you. Minus that, a new doctor is necessary. I hear the frustration in that comment. The part one want to carry forward is the call for monitoring and follow-up, not the instruction to change clinicians. Even good monitoring can miss the complete picture if the prescription list lives in one chart while the cold medicine, pain reliever, and nasal spray live in a drawer nobody asks about. So tell me in the comments, has a pharmacist or clinician ever asked you to put every prescription and every drugstore medicine on one list? A simple yes or no is enough. Please do not post private medical details. Number 2 is narrower than the category at number 5. A sodium-containing dissolvable calcium carbonate product used for stomach relief. Do not hear me say that every antacid contains sodium. That has not been established here. The precise point is that sodium-containing calcium carbonate was among the dissolvable medicines examined in the large British study. The study's finding applies at the formulation level. Compared with ordinary versions of the same medicines, people taking sodium-containing dissolvable, effervescent, or dispersible versions were more likely to be diagnosed with high blood pressure and had higher rates of stroke and death from any cause. Again, that is an observational association, not proof that sodium alone caused it. Why give stomach relief its own number? Because many people hear effervescent medicine and picture only a pain reliever or a vitamin. The fizz can appear in another part of the cabinet. This is also why I am not giving you a brand list. Formulations can differ, and the verified study does not justify treating every antacid as the same. A brand name encourages a yes or no shortcut. The better habit is to check the exact package in your hand and ask whether that exact dissolvable product contains sodium. Your one safe action is to bring the package to a pharmacist and ask, does this stomach relief product contain sodium? And is another formulation appropriate with my blood pressure medicines? No brand guessing. No home experiment. No change to a prescription. Just the label, the full list, and the question. Number 1 is not a claim that one class is the most dangerous. This countdown is a checklist, not a risk ranking. It is number 1 because the combination is easy to create without realizing 3 separate medicines have become one clinical problem. The setup is a water pill, plus an ACE inhibitor or an ARB, plus an over-the-counter NSAID pain reliever such as Ibuprofen or naproxen. Adding that pain reliever on top of the water pill and the ACE inhibitor or ARB is a well-documented combination linked to sudden kidney injury. Clinicians call it the triple whammy. This is not a story about a fictional patient. In a study using British primary care records, the risk of acute kidney injury was highest in the first 30 days after the pain reliever was added. Notably, taking only 2 of the 3 did not show that increased risk. It was the full combination that did. The institutional response tells you how seriously the interaction is treated. Drug safety authorities in Australia and New Zealand advise avoiding this combination. In 2018, Japan's health ministry advised against it in older patients. Advise avoiding does not mean these medicines are legally banned. It also does not mean you should stop a water pill, ACE inhibitor, or ARB. Nothing here means stop a prescription. The action is immediate and ordinary. Before adding ibuprofen, naproxen, or another oral NSAID, ask a pharmacist to check your full list. Do that even if the prescriptions came from different appointments, and even if the pain reliever is only waiting in the cabinet just in case. The interaction check works only when all 3 parts are visible at the same time. One prescriber may recognize the water pill. Another may recognize the ACE inhibitor or ARB. The pharmacist can connect those prescriptions to the over-the-counter box you are about to add. Say this: am I taking a water pill together with an ACE inhibitor or ARB? And would this pain reliever create the triple whammy combination? You do not need to know which class every prescription belongs to. That is the pharmacist's job. Your job is to bring every box into the same conversation. If you are not sure whether one of your prescriptions is a water pill, an ACE inhibitor, or an ARB, Do not guess from the shape or color of the tablet. Ask the pharmacist to mark those classes on your medication list. Then keep that list where it can travel with you, rather than leaving the prescription names in one office and the drugstore purchases in another drawer. Here is the entire plan. Today, put your prescription bottles and drugstore medicines in one place. Include the products you take only when you have a cold, pain, congestion, or an upset stomach. If carrying the packages is awkward, photograph the front and the active ingredients panel. Do not leave out a product because you take it only occasionally. Occasional products are exactly the ones most likely to be absent from a list created during a routine appointment. The purpose is not to produce a perfect medical file. It is to give the pharmacist an honest snapshot of what might be used together. Next time you shop, do not ask only, "What works for pain?" or "What clears a blocked nose?" Add the missing sentence, "I take medicine for blood pressure. Please check this against my full list." For pain, ask whether a topical anti-inflammatory gel or acetaminophen fits you better than an oral NSAID. For congestion, ask whether saline spray or an antihistamine fits you better than a decongestant. These are questions, not universal substitutions. This week, ask the pharmacist to identify 3 things on your list: any decongestant, any oral NSAID, and any dissolvable or effervescent product containing sodium. Then ask whether you have the water pill plus AC inhibitor or ARB combination that makes adding an NSAID especially important to review. Do not skip, reduce, or stop a blood pressure prescription because of this checklist. Bring the over-the-counter box to the professional who can compare it with the prescriptions. Let us clear away 3 myths. Myth 1. If I can buy it without a prescription, it cannot interfere with a prescription. The confirmed mechanisms in this video are exactly why the pharmacist needs both lists at once. Myth 2. I only plan to use the pain reliever briefly, so there is no reason to ask. In the study using British primary care records, the risk of acute kidney injury was highest in the first 30 days after the pain reliever was added. Taking only 2 of the 3 did not show that increased risk. It was the full combination that did. That is not a prediction for you. It is a reason to ask before the first purchase. Myth 3. The big sodium study proved that fizzy medicine causes heart attacks. It did not. The study was observational, so it showed association rather than proof of causation. A non-fatal heart attack, considered separately, was not increased. The elevated findings were a combined cardiovascular outcome, stroke, high blood pressure diagnosis, and death from any cause. Accurate information is not weaker because it is carefully worded. It is more useful. Fear tells you to throw a box away. Precision tells you which label to show and which question to ask. If nobody has ever asked what is in your bathroom drawer, your kitchen cabinet, and your drugstore bag, that is a gap in the conversation. It is not a failure on your part. You are not helpless in that gap. You can put every package on one table. You can read one active ingredient panel. You can ask, how does this fit with my blood pressure medicines? And you can keep asking until the answer covers the whole list. That is a strong, practical response to a system that too often divides one person into separate appointments, separate shelves, and separate questions. You are putting the person back at the center of the list. That is what being your own advocate looks like. Not distrusting every clinician and not changing treatment alone, but making it easier for the right professional to see what nobody has yet put together. Which category surprised you most? Cold medicine, pain reliever, nasal spray, or something that fizzes? Comment with the category only. Share this with the person who keeps one medication list at the doctor's office and another list in the kitchen drawer. Subscribe, because the next video will keep turning overlooked everyday details into exact questions you can take to a pharmacist or clinician. And remember the sentence that protects every prescription in this video. Nothing here means stop a prescription. It means bring the box to your pharmacist before you add something to it.